Yeah, is my screen?
Yeah. So good morning, everyone, to everyone in UK, and good afternoon to everyone on this side of the world in India and Asia. We welcome you all to OrthoTV UK in association with Northwest Education Academy to introduce today's speaker and the topic. I hand over to the moderator and course chairman for today, Mr. Nikhil Pradhan.
Thank you, Neeraj. Good morning, everyone. Good afternoon in India. Welcome to today's webinar on prosthetic joint infection, current trends and management. It is a very relevant topic to all of us. We have an eminent faculty, and you'll hear from Alasdair, Santini, Professor Peter K, Professor Shubhranshu Mohanty, and I'll moderate this session. It is streaming live on OrthoTV UK. And I'll take this opportunity to thank Neeraj and Ashok for supporting us on this. If you have any queries of future collaborations or any queries on clinical citations that you want to do with us, you can write to us on the email of Northwest Education Academy. I would like to acknowledge the educational support given to us by Herius and OrthoTVUK for the platform collaboration. So if I might ask Alasdair Santini to share his slides and talk to us on management of PJI in total knee replacement. Mr. Santini is a consultant at Liverpool University Hospital and Bone and Joint Center. He's an honorary clinical lecturer, University of Liverpool, and treasurer of the British Association of Surgery of the Knee. He has a keen interest in this topic, and I've always enjoyed having discussions with him on this as we chair our hospital MDTs. So thank you, Alasdair, for this talk.
Thank you very much, Nikhil. Thank you very much, everybody in the UK. Thank you much, everybody in India, and I hope you're all safe and well over there. I want to talk about the diagnosis and management, particularly of knee infections. As we know, it's a devastating complication. Depending on what papers you read, it can be up to 2% of patients producing significant morbidity, mortality, and a massive health economic burden. I want to talk very briefly initially on the acute infected knee. I'm going to concentrate on the chronic and perhaps infected knee, and then we'll come back into the acute bit as we go through. It's relevant all the way through. I've always found that using algorithms are one of the best ways of making sure we don't miss anything. So very quickly, this is a typical one. There are many of them out there, but this is one which we use here in the Northwest. For those of you who don't know, we've got a very well-established collaborative MDT of the 7 or 8 hospitals in the Mersey and Cheshire region. And a number of years ago, we sat down together to make sure we're all doing the same thing, treating patients in the same way, doing the same test and doing the same analysis. So this is one that we came up with for the acute knee. Starting at the top, you would obviously examine the patient, take blood tests and x-rays. And in the acute person, we need to get them to the theatre as soon as possible. And we've got one arm for when the wound is sealed and probably superficial, one arm on the right-hand side when you've got a leaking wound. But the same thing, it's a matter of analysis, taking microbiology, taking histology, which I'll come back to, and making sure the laboratory knows the samples are on their way, particularly if you're doing this on a Sunday morning when there may not be a full lab capacity. They know the samples are coming, then they can check them. You don't want samples sitting there for 24, 48 hours until someone picks them up on a routine day the following day. And as I'm not going to go through every bit of this slide, but as you see, it comes down. It's taking samples, taking appropriate samples, cleaning out the wound, awaiting microbiology, and then dealing with it with an appropriate microbiologist with a bone and joint interest, and right at the bottom, referring to a revision arthroplasty surgeon. These are cases that need to be done by people who know what they're doing, not necessarily just the first person that happens to be on call that day. So we'll kind of come back to that as we go through, but the one we most see is the chronically painful knee replacement, the one that didn't have any immediate problems, but at some point comes back with issues. So again, algorithms very useful. So let's start at the top. We have a patient that comes in, they've had no problems immediately, but the knee is painful. So you examine them, take lab tests, x-rays. And the first question is, it's septic? In the vast cases will not be septic. So we carry on down this left-hand side. Do they have a sinus tract? By definition, that is infected. So they would go immediately into a surgical procedure. The answer is no, and the majority will be no. Then we're coming down to joint aspiration, microbiology, leukocyte count, and then does that indicate infection or no? If it's yes, then we're going into a surgical procedure of some type. But if it's not, what else are we thinking of? We're thinking of aseptic loosening. Have they got a fracture? Have they dislocated their hip? Is it muscular? Is it somewhere else? And even if those are all excluded, then we're going to think, are we missing an infection? Is it there really, but we just can't pick it up? Do we repeat the aspiration, or do we even do an arthroscopic or open biopsy? So let's take this patient here. I said x-rays, but this patient actually came in not too long ago. X-rays of IB2 replacements many years ago, no obvious problems. But just sometimes I find CTs are quite useful. If you see the CT of this patient here, you can see an awful lot of bone loss with retrospectivity is present on the X-ray, and CT is actually quite a useful and simple measure. So let's take a patient. It's always easier if we look at things on looking at an individual patient. This is a patient, a 76-year-old man. He's a merchant sailor, had a knee replacement done about 15 years ago. He had a previous Birmingham hip replacement that was revised for aseptic loosening a couple of years before that. He was a keen golfer, but noticed more recently he could get to about hole 12, but no further. His knee was stiff. He felt it giving way. It was painful. It still moved reasonably well. He'd had 110 degrees since day one, so there's no change in that. It was stable, but it was painful when you palpated it laterally, though there was no effusion inside the knee. There was his knee. He'd had an LCS replacement. We could argue that the tibia is probably a size too big, but there was no obvious issues there. But if you look at the x-rays, you think, well, maybe there's a bit of loosening on that lateral tibial tray. We do aspirations as we would normally do. They come back as negative. There's low white cell counts. His bloods look pretty normal. So we're happy that he's got an aseptic loosening, and we revise it. And indeed, the tibia is loose. The femur is well fixed. We take samples, and they're negative for both microbiology and histology. So why do we take histology? Well, many of you will know about the International Consensus meeting in Philadelphia a number of years ago, a big meeting deciding what we would consider was diagnostic for infection. I've mentioned before, if a sinus tract is present, that is infected, irrespective whether the samples are negative. If you've got negative samples, but you've had a preoperative aspiration, they put on antibiotics that were tailored to that aspiration, well, that could still be diagnostic of infection. And then various numbers of identical soft tissue samples and either positive or negative intra-articular fluid samples. But there's some cases that come up when they're possibly, but not definitely. These certainly should be discussed at MDTs. So people who have got positive intraoperative fluid cultures, but negative soft tissue samples, or those who have got a number of minor criteria. And the minor criteria was raised CRP, ESR, synovial white cells of 3,000 or over, when you've got 70% polymorphs, single positive cultures, and positive histology. Because if you've got multiple identical positive microbiology, then we know you've got infection. But having negative microbiology does not mean there's necessarily no infection. And histology is one of those the tissue that we can take, which help us. Don't give us a definite diagnosis, but they certainly help. We presented this paper at Basque a couple of years ago, looking at our histology samples. The first question that was raised, well, it's an expensive thing to do. Well, of the 212 procedures that we presented, if you look at the price for both microbiology and histology here in the UK was almost identical. The extras was because one or two of those samples were done out of hours and added a little cost. But even if you take that into account, you've got a very similar cost. And I don't think, therefore, that means we should not be doing histology purely on cost levels. If you looked at the results, the majority of patients had no infection, and histology was confirmed that. Some did have infection, and again, the histology confirmed that. But those second, third, and fourth columns are ones when there's a difference between the microbiology and the histology samples. So 7% confirmed infection, we knew it beforehand, probably not much benefit of doing histology if you definitely know it's infected. And half of them confirmed the aseptic case. You thought it was beforehand, so it doesn't really affect the diagnosis, though you don't know what the samples are going to be until after you've taken them. So you need to have those histology samples just to confirm your diagnosis. 25% had a positive microbiology sample. We thought it was aseptic. And then you're in that question, you ask that question, is it a contaminant? And having negative histology on 5 samples, 5 histology samples, doesn't prove, but it gives you a bit more confidence that you're probably talking about a contaminant. And this is working in collaboration with microbiologists and histologists who deal with joint infection. I think that's very important, and that's certainly what we've pushed for here in Cheshire and Mersey. And then 4% had a difference in 1 sample. Some you were expecting infection, others you weren't. But again, it's helpful just to decide whether or not you think this is infection or not. And 6% had multiple differences. And again, whilst it didn't give you a definite answer, it gave you a bit more confidence in falling one way or the other. So if you add those up together, you got about a third of patients have got some alteration, and histology certainly helps, and we would certainly conclude that. So back to our patient, aseptic loosening of his tibia. So what have we done? We've gone down this algorithm, now in orange. We did our examination, we did our bloods, you've seen those. He wasn't septic, no sinus tract. We did our aspiration, didn't indicate infection. Other loosening is aseptic loosening, and so that is where we went for in this chap. We did a revision as to a legion. He did very well. I go on holiday, which is always a mistake because problems only happen when you're on holiday. And this chap was readmitted with a hematoma and twice was washed out by the person on call, not a person who was particularly familiar with opening up a knee. They took a few samples. They took 5 in each time, so 10 in total, and all were negative. But one of them grew a staphylococcus, only on a rich sample. They did what they were told to do and took histology. They were all negative, and the conclusion was that this was a contaminant. When I come back, he's still got a hematoma. I open up myself. There's a lateral gutter bleeder. We sort that out. I take my 5 samples. They're all negative. CSR and his CRP are very slightly raised, but everything seems fine, and he does very, very well for about a year. And then he comes in, he's out in the garden, and he cuts his leg. It gets a little bit infected, and very quickly his knee swells up. He gets pain. He's still got the same range of movement, but his ESR and CRP are now raised again. We take aspirations, and he's growing staph epidermidis. It's resistant to a whole host of antibiotics, which is obviously very worrying. But those are his X-ray, doesn't show any difference really. So we go down our algorithm once again, starting from the top. We're coming down, say aseptic patient. He's got no sinus tract. We're coming down the left side, but the culture suggests infection. And now we've got to make this decision. He's been okay for a year. We thought it was aseptic, first of all. He's got a source of infection, the cut leg. Do we do a DARE? So that's what we plan to do, because he's got, when we open him up, there's a single area of osteolysis, anteromedial tibia. Everything is really well fixed. If a microbiologist who looks at the samples, IV ticaplanin, Nezolic for 6 weeks, and then doxycycline for 6 weeks thereafter. But he doesn't settle. He doesn't really settle. His pain, he comes and goes. His ESR and his CRP particularly go up and down. They're never particularly high, but they're never normal. Aspirations are negative. His leg is occasionally red. And you then got a question, was it really infected all along? Was that staphylococcus right back when you had the hematoma? Was that the infection? And we've been led to a false sense of security that subsequent samples are negative. We decided really we've got no choice but to go in and do a 2-stage revision. And again, coming down our algorithm once again, we come all the way down that left side, right to the bottom. We've got ongoing suspicion of infection. We thought about doing further biopsies. We thought, look, we're going to have to go in. So we bypass that and go straight up and do, in this case, a 2-stage revision with a spacer, and then come back in again, put a metaphyseal sleeve in. He's got Stimulan beads in there with antibiotics in there. That was in January 2019. His wound heals up. His markers come down to normal. He has minimal pain. He does lose a bit of flexion, unfortunately, which is not surprising, but now he can walk the dog. He can't play golf, but he's a happy man. He was always unhappy before, but being a merchant sailor, for those of you who don't know, I used to spend a lot of time up in Glasgow in the 60s, and he'd go along to Celtic Park and watch the Lisbon Lions become the first team to win the European Cup. And this was his passion, talking about the Celtic team of the 60s. And he'd come into the clinic each day and tell me stories which I'd never really heard about. And you could tell that was just a happy man now. And there's his most recent x-ray about 6 months ago. So we did a dare, rightly or wrongly, and we'll talk about this, I suspect, throughout this morning. Dare, debridement, antibiotics, implant retention. When do we do it? Acute post-op infections within 3 months or symptoms of less than 3 weeks. You could consider extending it, and we certainly did. If you've got a well-fixed, well-aligned prosthesis, but you can be fairly confident you've got an acute infection, irrespective of the timing of the original surgery. If you think it's come from an acute hematogenous infection, that's more controversial. It's more difficult to know the length of time that's been around, and there's certainly a higher relapse rate. When do you not do it? Sinus tract is infected, that's not an option. If you can't close the wound, if the prosthesis is loose or it's malaligned, that's going to have to come out. That's not an option. If it's chronic, or you've got something that's difficult to treat, a multi-resistant organism. And again, another algorithm, there is a number of options, and I know Peter's going to talk about two-stage revisions and one-stage revisions. So basically everything on that right side of the algorithm we're going to ignore, because DARE really only comes to those acute PGIs that you've got good soft tissues, a stable prosthesis, you've got an organism you can treat, and that's there. And anytime you're going to move across the right, it's not really an option. It is open, it is radical, it is meticulous, it is not arthroscopic, it is not small wound surgery. This is opening up the whole wound and more to get in, and it should be done by someone who knows his way around a knee, and if you're doing it on a hip, know the way around a hip replacement. There's no role for arthroscopic debridement, perhaps only in a highly septic patient that you just need to debulk while they're on the way to ITU. Everything comes out of the wound, excision of the wound, all stitches, the vicryl, whatever other sutures that may be present in the soft tissues on the way down. Multiple samples for microbiology and histology, as I mentioned before. A radical synovectomy, exchange of modular components, and copious amounts of positive acetylene, betadine, hydrogen peroxide, Versagel, whatever you use. If the floor is not covered and the nurse has been running around getting more fluid for you, you've not been doing enough, basically. Curettage of the bone cement metal interface, and then perhaps Stimulan, as we did, to give further antibiotic elution throughout the procedure and in the post-operative time. Does it work? I just want to show you a couple of papers. This one, a couple of years old by ISA, looking at 26 knees on average of 76 years. The acute infections, they were on average of 22 days, whereas the hematogenous ones, which I've mentioned, have a worse result, they were out to 26 months. And with the acute infections, they were having a 93% success rate compared to the homogeneous ones, which were down at 58, statistically significant. And again, if you had Staph aureus compared to non-Staph aureus, that was a difference, as a significant difference as well. Can you anticipate who will do well and who will do badly? This paper is 3 years old from Bristol, looked at the click score. For those of you who are not familiar with this, you get marked in 5 criteria. So click, K stands for kidney. So you get 2 points if you've got a patient who's in chronic renal failure, 1.5 if they've got liver failure, 1.5 depending on their index surgery. Was it revision, a ready, or was it for a fracture? 2 points if it's cemented, and then 2.5 points if you've got a CRP of greater than 115. So 9.5 is your total score. And basically, they looked at 59 knees. If you score 7 or above, so you've got most of those criteria, your failure rate is 60%. But if you've got a click score of less than 7, you've got a failure rate of 28%. So it may not be surprised to hear you, patients who have got multiple comorbidities do worse than patients who have got a few comorbidities or a lot less comorbidities. Again, also, it's very much dependent on the kind of organism. If you've got a streptococcus, then you'll do badly. And this paper showed that there was a significant higher rate, both the streptococcus in general, but various types. And you can see their outcomes show statistically significant as you got those difficult to treat organisms. And once there's only one organism, there are many others which have very similar graphs. And finally, we here in Cheshire, Mersey have worked together, and nationally there's going to be regionalisation of all revision knee replacement. And people have questioned whether it works. Well, this is a paper from the Netherlands a couple of years ago when they did what we've done and what's going to be done in the UK up and down the country, agreeing with having regional MDTs for infections. And they sat together, 9 hospitals in Southeast Netherlands, and agreed in principles on who did DAREs and when they did them. So the hips and the knees were done by arthroplasty surgeons who knew their way around those joints. There was a general agreement on how they diagnosed infections, how they took samples, who looked at the samples, that the samples were looked at by a microbiologist with a special interest in arthroplasty revisions. They had a regional review of the results, and they registered 310 infections. 236 of them were acute infections, so about 1%. But before they did this, their success rate for DAREs were 45%. And afterwards, when they'd all agreed on principles, it rose to 70%. And I was at a meeting most recently, and there's more up-to-date data which they presented, which shows it's even higher and now, showing that collaborative work and agreement of principles really is the way forward. So I've very briefly gone through some peri-prosthetic joint infections. We know it's a devastating complication. Having a stepwise diagnostic algorithm, I think, really helps make sure everyone is doing the same thing, getting the same answers. Taking microbiology is important, but also histology, I would argue, is important as well. Making sure that revision orthoplastic surgical teams are looking after these patients, particularly if they're doing a DARE. And then, if in doubt, moving on to a 1 or 2 stage revisions, which I think Peter's going to discuss about the pros and cons of both of those. Thank you very much, everybody.
Thank you, Alasdair. That was a really very good talk and a lot of very relevant papers that you've presented, which we can read. And you're right, there'll be a lot of discussion. I can see some questions coming through. We'll take those at the end. If I can now ask Professor Peter Kay to start sharing his slides. Professor Kay does not need an introduction, but I'll go ahead because I like reading what he's done. He's a consultant at Wrightington Hospital. He's a clinical professor of orthopedic surgery, Manchester University, past president of the British Hip Association and British Hip Society, previous national director, clinical director, musculoskeletal services, NHS England, and he's currently a council member of the Royal College of Surgeons of England. Peter has always been a mentor to me throughout my career in the UK, and it's always wonderful to listen to you, Peter. So thank you.
Thank you very much. Can you see that? Is that sharing?
It is, yes. Thank you.
Okay, so thank you very much for the introduction. All it means with a CV like that, you just happen to be very old rather than very eminent, I have to say. But there we go. So I want to talk about single stage, 2-stage revision. So if we're talking about infection in joint replacement surgery, there are a number of options open to us. I mean, you can just give antibiotics alone, which you rarely achieve success with that. There's antibiotic suppression in the old and infirm patient, which I think is a really important thing to have in your armamentarium. I think there is a case sometimes for not revising, but just to suppress. You can do surgical damage. You can do the DARE procedure has been discussed, and that's really quite important. And I would agree with Alasdair. I really think it's important that you get agreement about DAREs. It's not something that everyone should just be doing. You know, it's really important that that's done well. You can do partial revision with antibiotic therapy that has been described, not performed that often. But of course, the 2 choices really open to us is about 2-stage revision or 1-stage revision. And there's lots of discussion around that. And I think there's much more to it than just trying to decide whether you're going to be a 1-stage or a 2-stager. And a lot of that's got to do with whether you can actually put in a new joint, actually. So what we're trying to do surgically when we're treating a joint infection, well, okay, there are principles of how do you treat musculoskeletal infection. how do you go about closing the dead space, giving stability, allowing the tissues to heal? There's a science behind our treatment of infection. I mean, whatever we do needs to sort of fit with the immunology of the situation. How does the body react to foreign material? But when we're talking about 1 and 2 stage revision, there are more than one endpoint to discuss. Sure, there's the endpoint of have we eradicated infection, but also there's the endpoint of, have we actually been able to get a new joint replacement into the patient? And actually, what's the clinical result like? Because, it's a very surgical approach to say we've got rid of the infection, but if the patient thinks it's absolutely rubbish, it's not, you're not really achieved a lot. And then, of course, we do need to consider the morbidity and the mortality of having maybe more than one major surgical intervention, and look at the quality of life in between 2 stages of a 2-stage revision. What is it that you're having to manage during that time? And largely, if you're doing 1-stage revision, you're going to end up with a cemented prosthesis, and you need to look at what the overall long-term results are of the type of prosthesis you might use. And then I think there's a really valid point about trying to think about the health economics of the situation that we find ourselves in, because the money at the end of the day probably does matter. It certainly matters to society, and it does matter to individual institutions as well. So what about the treatment, the principles of treating infection? Well, these are sort of principles that were sort of learned during wartime mostly, I suppose. Removal of infected tissue and foreign material, closing dead space. Mechanical stability is really quite important, I think, particularly for the soft tissues to recover. To identify the organism, sure, and use relevant antibiotics. And, maybe do local institution of antibiotics, things like stimulant that were discussed before, as well as systemically. So if you're looking at 1 and 2 stage revision, I mean, 1-stage revision actually achieves all the principles of the treatment of infection. You remove the implant, you fill the dead space with a newly cemented implant, you're fixing it to the bone, you're stabilizing it, you're giving a sort of an axis of rotation, the tissues can recover, and really allows the body to manage the infection. So, 1-stage revision does fit really quite well with the management, the principles of the management of infection. And of course, if we're doing a 2-stage revision, we have the same principles there, actually, because for a successful first stage of a 2-stage revision, again, you really want stability, you really want to close the dead spaces. And of course, as we'll go on and consider, of course, there are some attempts at 2-stage revision where you don't actually achieve much in the way of stability, or the implant is rather loose. And maybe that's not so great at getting rid of infection, even though it's a 2-stage revision, because the first stage is left you with a rather sort of, either a poor space or a poor environment which isn't stable. Now, if you think about the science of what we're trying to do here, the immunology, okay, so we know that if we've got foreign material, it's difficult to clear infection with all the sort of surface phenomena. And of course, there's the elevated ESR and CRP, and it's quite interesting, Alasdair's slide there, where it's considered that having a high ESR and a high CRP may not be great from the point of view of Adair. But actually, when you start to think of what is ESR and CRP, it actually isn't a measure of anything the bacteria is producing. It's a matter of really of the immune response of the host, the patient. And that ESR and CRP, so that's really measuring the immune proteins. All of those immune proteins are aimed very much at the organism you're trying to eradicate. So I actually almost believe that your ESR and your CRP are your friend in 1-stage revision, because that means that the patient's immune system is really wound up to get rid of the very organism you want to get rid of. And when you then clear the dead space, fill the dead space, get rid of the infected material, you allow the blood supply to get in, you're then allowing the patient's immune system, as a reflecting the ESR and CRP, to actually attack the very organism you want to get rid of. And that's probably why 1-stage revision works so well, in a sense, because obviously it's still contaminated. When you've done a 1-stage revision, even if you're changing instruments, being very meticulous, you must still have a significant bacterial load. But the fact that 1-stage revision works there must mean that the host is then taking control at getting rid of those those bacteria that must be present. So rather than think your ESR and CRP is your enemy, I would perhaps dispute that. And I think when you see those sort of cases where you really struggle to get rid of infection, sometimes those are the cases with very low-grade infection, very little in the way of an immune response. And if the patient's immune system is not on your side, maybe it's more difficult to get rid of infection. And of course, if you think about two-stage revision, what you do is you do the first stage, and okay, the ESR and CRP are very high, and then you wait for the ESR and CRP to come down before you do the second stage. And that makes you feel reassured. But does it make you feel reassured? Because actually all you're doing is waiting for the patient's immune system to go to sleep. And so you perhaps lost that little bit of help that the immune system might give you. And again, I would argue, and we'll go on to the results, why does one-stage revision work when it clearly does? Now, I think it's important to look at the endpoint as judged by the eradication of infection. So if you're comparing two series, so if you're looking at a two-stage series, there are a number of patients that never get the second stage. And largely when people present series, they've often looked at all of the patients that have actually had a second stage, and the others are sort of lost to the study. Yes, with one-stage revision, because you're not necessarily offering one-stage revision to everybody. So there's some patients that will never have it in the first place. However, with one-stage revision, the patients have had a revision, and therefore those results are available for comparison. So in a sense, sometimes the superior results that are sometimes reported with a two-stage revision have lost a number of patients along the way who have never made it to the second stage. And I would argue that that might be what gives you what looks like the slightly more superior results. Now, there's been lots of meta-analyses about this, and a number of groups have, Alasdair referred to some of the groups that have looked at these from across the world, some international sort of studies that have brought it all together. And there's really very little difference, actually, to choose between the results of one and two-stage revision when you really look carefully. And that's interesting, because people always assume that sort of doing two operations, it must be better. You know, you've got two goes to get rid of the bacteria. Well, in actual fact, there's not a lot to choose. And we've informed study that's done recently, looking worldwide for infections and reinfections. Again, if you want to be a one-stage reviser, are reassuring in terms of the results are really very comparable and very good. Now, I do think that the mobility and mortality is really quite important, particularly with old people with infection and sepsis. And I really think one-stage revision, particularly in the hip, is so good in the older infirm patient, because it's one operation, it works, you can get the patient up on their feet. You haven't got a long period of dysfunction where the patient goes off their feet, loses muscle mass, and will really struggle to get going again. And I think if you're going to start anywhere thinking about one-stage revision, the older patient is a really good place to start to think about using this technique and develop confidence in it. Now, of course, if you're doing a two-stage revision, you can use an articulating spacer, and whether that's in the hip and certainly in the knee. And I went through a phase in my career of actually doing two-stage revision with a lot of spacers. But the problems were that, you know, patients actually quite liked the fact that you put a spacer in them and you'd got rid of the infection. And some of them didn't really want to give it up, even though it was meant to be temporary, and you were seeing acetabular erosion or even fracture of the cement spacer or dislocation of it ultimately. But because the infection had been sort of eradicated with that, the patient was happy to sort of think, well, I may just stop now, even though the functional result's not great, I've not got infection. And it really begs the question that if you can put an articulating spacer in often, well, why not actually just do a one-stage revision and put a definitive prosthesis in right from the start? And, you know, and the idea that you do a first stage of a two-stage revision and deliberately cement something in badly or not at all, I think is probably not the best way to think about it. I mean, if you don't like the idea of one-stage revision in some senses, what you can always do to sort of take the heat off your own decision making is to say, well, actually, I'm not really doing a one-stage revision here. It is maybe it is a two-stage revision, but I'm using a definitive prosthesis for the first stage, and it may well be we never actually get around to needing to do the second stage, and we've sorted it all out with the first stage. And the fact that you avoid a second operation, most of the time, one stage revision is definitely the place to go. Of course, you need to look at the long-term results, of course, and cemented joint replacement does actually work quite well in the long term. But here's a real crux to one-stage revision, I think. And it's really the same with primary joint replacement surgery. At the end of the day, the whole purpose of the operation is to actually fix in an implant. So the decision-making, to me, the most important thing is that after I've removed the implant, whether it be a hip or a knee, if I'm happy that I've got enough cancellous bone to actually fix in a new implant, then I feel really quite reassured. I'm happy to do a one-stage revision. If I'm in the situation where I haven't got good bone, I think you can have the bone doesn't have to be perfect. And we've done some studies on that at Wrightington where we've looked at bone stock, and you can get away with there being not great bone, but you've still got to be able to fix the implant. So the real decision-making tree, from my point of view, is that can I really fix an implant in? And if I can fix an implant in, then I'll have no hesitation to go to a one-stage revision. So, I mean, many cases from Wrightington over many years. There's some sort of 20 years down the line from the infected furlong. And even though, obviously, in this case, I didn't actually manage to remove the screw here. So there must have been probably some residual tissue. There was one broken screw left. I mean, I've seen the guy more recently, more than 20 years down the line now, he's still infected free. So it really does work. And the difference between revising someone straight to a definitive prosthesis and they're on their feet straight away, as opposed to a two-stage with limited weight bearing in between, is just enormously different. There's a couple of recent publications about the fact that the function is probably better moving straight, having a single stage revision. Now, the time, of course, you can't, or in my hands, where I'm not happy to do a one-stage revision, is where you've got massive bone loss and I want to use bone grafting, bone impaction grafting or structural grafting. And so far, I've not really had the courage to do bone grafting in the presence of infection as a one-stage revision for deep infection. I mean, there are some surgeons in the world that have done that. There's some quite large series from South America, actually, where people have sort of washed the bone graft and gone ahead and done a one-stage revision with bone grafting. But in my hands, I've not been happy to do that. So contraindication for one-stage revision in my hands is if I do want to restore bone stock. And my other one is when I'm doing one-stage revision, I much prefer to do that if I can get away with using primary implants. That I wouldn't suggest you did one-stage revision if you're going to have to use very long implants, or say massive extended trochanteric osteotomies, where you really risk perhaps infecting the bone, the larger sections of the bone. So one stage, and because infection is painful and people are unwell, infections do tend to present early. So actually, what you discover, and I'll come on to the data, that more than 70% of patients I see from an infection from a primary are definitely suitable for one-stage revision. There's enough bone stock, and the chances are you can use relatively short implants to be able to do a one-stage revision. And of course, bacteria have changed over the years, and it's a series from Wrightington. We can sort of see, as we've seen, multi-resistance has developed over a period of time. And when we started off at Wrightington doing one-stage revision, really following on from what Buchholz's work, originally the bone cement we had was just plain bone cement. We had nothing in it at all. And then we had gentamicin cement, gentamicin-loaded bone cement. And then we went through adding extra antibiotics to the bone cement that already contained gentamicin. And in doing that, we were able to sort of increase the sort of spectrum of the number of bacteria that were sensitive to the mixture of antibiotics that we were using. And quite interesting slide, a very old slide. So the first line, the dark blue line, was our results of one-stage revision for deep infection in the hip when we just had plain bone cement. There was no gentamicin in it, no antibiotics at all, and obviously there was quite a rapid attrition rate for that. The pink line is just gentamicin. This obviously is a series which is a later series now, because gentamicin was only available later. And so having gentamicin did improve significantly in the survivorship. And then the green line is gentamicin plus additional antibiotics. So over years, despite the fact that the bacterial resistance effectively has increased, we've been able to keep ahead of the game and improve our survivorship by adding different additional antibiotics. And if we look at some bold figures, sort of 7-year survivorship for those series, see the 7-year survivorship for plain cement, for gentamicin, and gentamicin plus the additional antibiotics. So despite the fact that the bacteria have got worse, the survivorship has got better. And yes, sure, we see mostly Staph epidermidis, really. Staph aureus has been gradually becoming more of an issue than multi-resistant Staph aureus. And that's from right into the figures where we've seen the organisms causing the problem. Coagulase negative staph has gradually reduced over time. Staph aureus has gradually increased. And we've added a variety of different antibiotics to the gentamicin cement. I mean, obviously there's some proprietary brands that are available as well. And we looked in detail of our use of extra antibiotics, obviously very different sort of macroscopically what the powder's like. And Anil Gambhir, part of his thesis working with me, we sort of measured the structural strength. And despite adding lots of extra antibiotics to bone cement, whilst you could affect the mechanical properties slightly, when we actually reviewed clinical cases, and this was a review of 316 revisions for deep infection cases, actually we actually saw less fractures when we were adding even more antibiotics later on. And I mean, that might reflect perhaps improving cement techniques, but really the idea that somehow putting extra antibiotics in bone cement makes it so weak it's going to fail isn't really not borne out by the evidence. But what really is important if you're going to put extra antibiotics in bone cement is to understand what effect extra antibiotics has on the bone cement itself, and to understand how it affects the working time of it. Because if you're doing the operation and you then start to maybe add additional antibiotics and it's really affected the way the bone is going to set, what you don't want to be in is the situation with an infected case whereby you've put the cement in, you've pressurized it, you're going to put the components in, but then you discover that it's really delayed the setting of the cement massively. You don't want to be hanging around for ages waiting for the cement to set when the bone interface is bleeding, producing a sort of a layer of blood between the bone and the cement. You want it to fix as quickly as you can without it bleeding. So to understand, and the same goes for proprietary cement as well, really, that if you're suddenly deciding to use a proprietary cement, an off-the-shelf one with that additional antibiotics, if you've never worked with that particular cement before, you've got to be very careful to understand how it's really going to set and how it's going to perform surgically. So I think there is a case, and to have seen the cement before, or to have some experience of it, or try it in the lab to understand where you are. Because at the end of the day, you want to fix your implants well because you're looking for a long-term result, not just a short-term eradication of infection. Now, when we reflect on what we've done at Wrightington over a period of time, we did go through a stage in the sort of the early and mid-noughties when we were using a lot more bone graft at one stage. And we were perhaps using more bone graft than we needed to. But that put us off doing one-stage revision a bit because we were looking in cases thinking, well, we've taken the implants out, maybe the bone's not great, maybe we'll do bone grafting. And that was more likely to push us to do a 2-stage revision. We've probably slightly reversed that back again, whilst we're still absolutely committed to the use of impaction grafting and bone grafting. It doesn't have to be absolutely perfect in terms of the fixation with cementing. So I think we've sort of found a more sort of steady level with that. Now, yeah, sure, we've got the massive cases, and you know, where absolutely you couldn't do a one-stage revision, and that, you know, there will always be a two-stage operations, as I said, will the cases with lots of extra bone graft. If we look at our bald figures, we're actually, our one-stage revisions do slightly better than our two-stage revisions in terms of survivorship at Wrightington. But that, of course, is because we're tending to do the two-stage revisions in the really bad cases where there's been really massive bone loss, etc. So they're not directly comparable. And that's why you can't really compare one-stage and two-stage directly in terms of the series that are presented. Whereas in individual cases, you know, you can randomize cases between groups for sure. And, well, you know, when you look at the costing, vast difference. A one-stage revision from the National Joint Registry, relatively cheap. Both stages of a two-stage revision are actually really expensive. So if you can do a one-stage revision for deep infection, there are some real economic benefits to that. So what we've discovered really, that certainly one-stage revision, you know, it's logical, it works, it supports the science, it's better for the patient. 70% of the time you can do a one-stage revision, and my argument will always be to do a one-stage revision where I can, and that's for both hips and knees. We have looked at antibiotic sensitivities and multi-resistant organisms and really haven't been able to detect a massive difference between super resistant organisms as opposed to not, where one and two stage revision is concerned, as long as you have some antibiotic which will work. So I think overall, when you're thinking about one and two stage revision, I don't think it's a simple binary choice. I really think you have to tailor the treatment to the patient that you've got and what would be appropriate for them. But largely, if you could fix an implant, I think you should do a one-stage revision. It's logical, it definitely works, and I think it's better for the patient at the end of the day. Thank you very much.
Thank you, Peter. That was really good. And I've always enjoyed that philosophy of yours of ESR and CRP being your friend rather than your enemy. It always makes you think about it. So thank you. There are some questions, but we'll take them at the end of this webinar. If I can invite Shubhranshu Mohanty to put up his slides. Professor Mohanty is unit head of orthopedics at the King Edward Memorial KEM Hospital, Mumbai. He's a postgraduate teacher, University of Mumbai. He's the present president of the Indian Arthroplasty Association, and PJI is an area of interest for him. And he also has a very good series on treating patients with hemophilia. He's been a good friend and colleague from back home. So Shubhranshu, if you want to start your presentation, please.
Thank you, Nikhil. Am I good? My screen is visible?
It is, thank you.
Okay. Thank you, Nikhil. And it has been a pleasure and honor to be invited by Northwestern, Education Academy for this lecture. And if I remember 21 years back, I was a fellow with Peter in Wrightington Hospital, and Nikhil was my colleague. And still, it is nostalgic to remember those days at Wrightington and do some work on infection with Peter, where actually I developed my interest was treating infected joints. Now, I will cover the talk from an Indian perspective. Now, it's always a teamwork, along with arthroplasty surgeon, the microbiologist, infectious disease specialist, and a good laboratory backup with facility for doing extended culturing the mycobacteria, especially tuberculosis is common in our country. And of course, the fungal culture, it should be available. And as I feel, there should be dedicated centers should be devoted for doing the infection work. But unfortunately, this type of dedicated centers for infection is not available in India. But definitely the whole treatment or whole management of the infection revolves around a cost-effective treatment. What Peter told during the last part of his lecture, it's extremely important in India to think as a consultant that how the patient money could be saved or how you provide a cost-effective treatment for the patient. We follow the 2011 guidelines, AOS guidelines for diagnosing a peri-prosthetic joint infection, as all of us know. And the crux of this diagnosis remains on isolating an organism and selecting an antibiotic which is sensitive to that particular organism so that you can treat or eradicate that infection. Now, this algorithm we follow for diagnosis is almost similar with Alasdair. What is shown that if a patient is suspected, clinically suspected for infection, then first we do ESR and CRP. So either both of them may be positive or either of them positive, we proceed to joint aspiration. Joint aspiration remains the hallmark that to diagnose the infection. And after we aspirate the joint, we send it for total count, differential count, as well as the culture. And if both of them are positive, then infection is likely. But if either of them are positive, then we put the patient off the antibiotics for 2 weeks and again repeat the aspiration after 2 weeks. Then the third step involves that after a repeat joint aspiration, if either of them are positive, then probably you need to treat it like infection. But if both are negative and implant is loose in the X-ray, so you have to plan a surgery, then intraoperative frozen section will depend on, and more than 10 polymorphonuclear leukocytes for hyperfield provides a diagnosis of infection. But the dilemma remains when the implant looks well fixed and you have not planned for surgery, then the patient should be off any antibiotics for about 3 months and keep it under observation, and then again repeat the whole algorithm after 3 months. The role of nuclear imaging is very, very limited, but still some surgeons in India do, nuclear imaging like PET scan or any indium level bone scan, etc. But its role is very, very limited in the diagnosis of infection. The 2018 criteria which has been given for PJI diagnosis is not very much followed in our country because, the leukocyte esterase, the alpha defensin test, they are not available in many, many centers, and hence it is not very popular to diagnose infection following this criteria. So the modified classification from 2003 onward that we are following, the type 1, which is added the positive intraoperative culture supposedly for aseptic revision. And sometimes we are surprised to see that it could be due to tuberculosis, which is not common in UK or any of the European countries, but it is very much common in India. That to more and more resistant tuberculosis is evolving in our country. And the treatment of infection, it remains on antibiotic therapy, debridement and irrigation with component retention or removal. And if you're removing the components, 1 stage or 2 stage implantation, that's what Peter was talking to you in detail. And finally, the orthodesis or resection arthroplasty remains depending upon the knee or a hip surgery. And in India, most of us, we follow 2-stage reimplantation, and that's the gold standard here in our country. Now, the type 1 is a positive intraoperative culture that gives you a surprise after the patient is already, you have put a joint in, just as for the culture sensitivity report, you have to treat this patient for about 6 weeks of antibiotics. In each and every case, we send histopathology. Though Alasdair told you that histopathology may have a limited role when you are sure about an infection, but we do histopathology, look for the COX or tuberculosis in our country. And sometimes you may find fungal hyphae in this histopathology also. That may give a clue to the patients suffering from fungal infection when especially in diabetics and patients who are on immunosuppressant drugs. So the dictum is all cultures must be biopsied and all biopsies must be cultured. This is a 38 years young male, following trauma, multiple procedures, plastic surgical procedures, then followed by a joint which got infected. So 2-stage reconstruction was done, multiple surgeries, infected scar tissue. And during the 2nd stage, though it was not looking infected, but the samples from one of the sites from tibia showed the growth of MSSA, which was treated for about 6 weeks with the appropriate antibiotics, 3.5 years follow-up of this patient. This is one of the patient, a 24 years young male, total hip arthroplasty was done for untreated fracture acetabulum. 5 years back, presented with pain and limping. And as you can see here that there is a loosening of the acetabular component, and there is a subsidence of the stem as well. So during surgery, as you can see here, healed scar, the entire femoral component was very loose, and it just came out by hand like that. You just pulled it out without any bone on growth on this. And cerebellum also came out, and you can see that there is hardly any bone ingrowth in this kind of in this, and there is no bone ingrowth on this acetabulum. And so intraoperatively, since it are not looking infected or no granulation tissue, just we did a revision surgery, putting the bone graft there. But the histopathology showed that there is a superimposed granulomatous disease consistent with tuberculosis, and he was treated for about anti-tubercular treatment for about a year. And this is more than 5 years follow-up of this patient, showing no recurrence of the infection and restoration of the biomechanics of the hip. The type 2 early postoperative infection, where you can treat with antibiotics or go until the debridement. And antibiotic suppression, especially, we are very concerned about, because it may control symptoms, delay another operation, but not strictly curative. So it is reserved only for chronically infected patients who are reluctant to undergo surgery. So it will sort of chemoprophylaxis. But one must remember that this antibiotic should be available in the oral form, and so that it can be given for a longer time without much of side effects for the patients. Otherwise, antibiotic side effects will outweigh the treating the infection. So we saw antibiotic resistance because of inadvertent use of antibiotics. In 50s, we saw penicillin resistance, 70s, methicillin resistance. Now 2002 onwards, we are seeing vancomycin resistant Staphylococcus aureus. We published a paper from Wrightington after my fellowship with Peter K. And we saw that about 9,000 patients, only one deep infection with MRSA. That is because of the routine screening of MRSA in patients who were admitted to Wrightington. But on the other hand, we saw more than 55% of patients with methicillin-resistant coagulase negative Staphylococcus. That was the cause of deep infection in the infected joints. In India, people inadvertently use antibiotics for prophylaxis. There is no clear guidelines, no uniformity on giving prophylactic antibiotics. It's told that higher the antibiotic chosen by the surgeon for prophylaxis, the lower the confidence in his setup. So hence, one should not use antibiotics for higher antibiotics just for prophylactic purposes. Now, Alasdair has told you about the diet, debridement, antibiotics, implant retention. It is indicated when the joint age is less than 3 months, or the onset of symptoms is less than 3 weeks. And it gives best results when there is short duration of onset and a stable implant inside in an immunocompetent host. Whereas it should not be done as an emergency procedure immediately. It should be kept for the next, routine theater, maybe next morning. But one should avoid it in chronic infection, presence of a sinus tract like this, or if there's a loose prosthesis. And the results are poor in rheumatoids when there's a high ASR, or when there's a resistant organisms like MRSA or gram-negative bacteria. Technical aspects of DAIR is that, you have to do a thorough debridement, take out all the granulations and all the synovial tissue from the suprapatellar pouch, from the gutters. Especially, one need to curate out at the bone cement interface and cement prosthesis interface, because there the granulations are there, which causes osteolysis. I will do a thorough, lavage. I do with, betazen, hydrogen peroxide, use the pulsatile lavage in low pressure, and minimum 9 to 12 liters of normal saline with the antibiotics may be used. And sometimes we may use, anti-biofilm agents like chlorhexidine or ciprofloxacin. All these things, they help in removing the biofilm, and do the suture with monofilament nylon. So at least 5 to 6 tissue samples should be sent from the most inflamed site and should reach the lab as soon as possible. And the growth should be in an enriched medium for at least 14 days. And as I told earlier, that always the tissue is sent for histopathological examination in these patients. And after you do a thorough debridement, the success of DAIR remains how thoroughly you do the debridement. That's what we tell the oncological debridement is possible. This is a 56-year-old lady, bilateral sequential TCAR, left knee got infected, and this is after the DAIR procedure. And we always put them to put stimulant or the antibiotic impregnated calcium sulfate pellets like this in suprapatellar pouch and parapatellar gutters. And this is infection free for the, after about 4.5 years. Now, these are the outcome studies compared to current literature. The results of DAIR is about more than 76% in our study, and mostly the coagulant negative staphylococcus, which is grown. And the predictors of poor outcome is it's a knee infected knee, or if there's a high ASA grade, the patient has got a high risk for anesthesia. Type 3 is a basically acute hematogenous infection where there was an interval period of well-being and then the patient deteriorated. And type 4 is basically chronic infection where 1-stage or 2-stage exchange is done. Though 1-stage exchange is quite successful in Peter's hands, though it shows a superior functional outcome, but if you see the literature, the 1-stage exchange has got 34% greater adjusted risk of reinfection than 2-stage reimplantation, and hence we follow 2-stage exchange, that is the gold standard. Though the interval period you treat and eradicate the remote site infection, but one must remember we should leave this patient, give an antibiotic holiday for about at least 6 weeks in order to see that whether the patient is immunocompetent host to undergo for a reimplantation, because there the issues on the cost lies and cost of the joint lies. And second stage reimplantation, again take cultures from multiple sites, and if in doubt during second stage, also do a frozen section to look for the more than 10 polymorphonuclear leukocytes for high power field. Now the prefabricated spacers are very expensive in our country. They're limited sizes and lengths, and hence we prepare our own spacer using our 100% medical grade silicone. These are polysiloxane. These are reautoclavable and reusable. They are soft, malleable. You can adjust the offset, you can adjust the length and adjust the diameter and adjust the version as well. And it provides rotational stability and easily removed during the second stage. By this, you can adjust the offset as I'm showing there. And you can put one of these implants like a K-nail or a Elijah rod or a V-nail or a Russ nail, whatever, and it provides a complete modularity. This is a short video showing how we prepare antibiotic spacers for the hip. And this particular patient which I'm showing is a 56 year or 55 years old female with an infected, dislocated bipolar arthroplasty. So while putting the incision, we incorporate the incision in the sinus tract to excise the sinus tract. Then we extract the prosthesis along with all the cement and foreign bodies, whatever possible. Do a thorough lavage with hydrogen peroxide, betadine, and antibiotic impregnated normal saline. Then we bend the K-nail or iliac rod to give desired degree of next up angle or desired degree of offset. These are the various sizes of templates which are available. These are reautoclavable, reusable. Then we add antibiotic to the cement powder, especially vancomycin to the gentamicin impregnated cement, and mix it thoroughly. Put it inside the template like that, and fill the template with the cement, and then put the K-nail or iliac rod which has been bent, and hold it and keep it pressed till it sets. At this point of time, you can alter the offset by putting in a proper position of this bent K-nail. Whatever cement is left, you can prepare antibiotic cement beads using the stainless steel wires. Now, just before it sets, we can take it out and trim extra bit of cement which is there all around with a nibbler or a bone cutter. Now this template is ready for insertion, and this shoulder part provides rotational stability. We just put it snugly and hammer it so that it fits snugly to the proximal part of the femur. If it doesn't fit snugly there, you can use another packet of cement and put it in the calcar. And there in the soft tissues, we put this antibiotic impregnated cement beads, and that is the post-operative X-ray. So the patient can be mobilized immediately with some kind of support that provides good stability and provides a good well-being for the patient. We published this in Indian Journal of Orthopaedics in 2013, showing a good outcome of this templates. This is a 52 years old male. The first spacer was put by a surgeon. There was still cement was left. Infection didn't get controlled. Second surgeon did a ETO, but the cement spacer was not stable. Hence, we put a third spacer using our templates, and then subsequently converted to a uncemented kind of total hip replacement. That is a 7 years follow-up of this chronically infected patient. Restoration of the hip biomechanics, restoration of the function, and there was no recurrence of the infection. So all foreign bodies, including cement, needs to be removed because that removes the biofilm to the extent as far as possible. Infection doesn't get control in presence of instability. So your spacer has to be stable enough so that patient can be mobilized, and biology takes over when infection gets controlled. Now in the knee, though we prepare 2 contoured static spacers with silicone modes which are available, we can prepare like this and put it like this. If these are expensive or if it's not available, you can do the molding like this on the table using the tibial polyethylene on the femoral side, and take the femoral component, do a molding on the tibial side, and after putting that before the cement set, you look for the stability of the knee. This is a infected, dislocated knee, infected for more than 16 years. There is a discharging sinus there. So here, when the joint is unstable, we prefer to put a stable static spacer there. So we prepare the spacer like this, taking 2 5cc syringes, joining them, putting cement dowels along with K-wires inside. And then we put one of the dowels inside the femoral canal, one on the tibial canal. And then we pack up the cement in the spacer, putting a static spacer, and that is the post-operative X-ray. So this multiply moribund patient who has been bedridden for a long time now can walk with some kind of support there. Of course, in this kind of patients, we put all this calcium sulfate antibiotic impregnated pellets inside the medullary canal. So that takes care of the intramedullary infection where antibiotics are unlikely to reach there. So patient can be mobilized here. Now, recently, again, we have prepared our own spacers using 100% medical grade silicone. They are polysiloxane, reusable, and autoclavable. So these are the spacers that couple of sizes available. Now it is at the commercial, not for commercial use, we are using only. So this is the way you put the spacer. That is how our X-ray looks like after putting the spacer there. And that is the second stage reconstruction. And that is almost 4.5 years follow-up of this patient, good restoration of the function because of the articulating spacer there. At last, excision arthroplasty remains the option. Of course, one need to follow that. The calcar should hitch against the superior part of the acetabulum so that you don't attend too much of shortening. Nowadays, this calm tighten nail you are using in some patients who are affording, which provides a very good stability for doing a orthodesis, knee orthodesis after a failed second stage reconstruction. So to conclude, yes, sir, CRP aspiration still remains the hallmark of diagnosis in infected joints. One need to have a high index of suspicion for tuberculosis or coughs and atypical mycobacteria as well, and also fungal infection, especially in case of diabetics and patients with immunosuppression medication. One need to get out of the antibiotic resistance and judiciously use antibiotics depending upon the culture and sensitivity. And judicious decision to do a DIAR is essential to prevent a recurrence or reinfection. For our country in India, 2-stage revision still remains the gold standard. One must learn the techniques of a stable spacer preparation for hip as well as for the knee. And of course, if it fails, one need to learn the techniques of orthodesis or excision arthroplasty. Again, I thank you for a patient hearing.
Thank you, Shubhranshu. That was a really, really interesting talk. I can see that you've used a lot of ingenuity and your experience from Wrightington and the UK, and yeah, it was really nice to listen to you. If I might now ask the panel members there are some questions that I've picked up, and one quick and easy one is post-op antibiotics. Do you give them for 6 weeks, 3 months, or until ASR and CRP go back to normal? If I can start with Alasdair and then Shubhranshu and then Peter, please.
We've changed more recently. We used to give for many, many months, and it was almost just the longer we give them, we just kind of feel slightly better. But our microbiologists are more of the view. Antibiotics are not the treatment. The treatment is the surgery. So the surgery's been done correctly, and we've done whatever it was, a DAIR, 1-stage, 2-stage. Then they're on appropriate antibiotics, probably for 6 weeks, maybe 3 months in isolated cases, and then stop. And there's going to be a reason for longer. There'll be a small percentage of patients who we're trying to chronically suppress, people who have got multiple medical problems that we accept we're not going to deal with the infection, but they're a small percentage. So 6 weeks for the vast majority.
Thank you. Shubhranshu?
Yeah, if you're doing two-stage reconstruction, then in the first stage, we continue with the antibiotics for about 6 weeks and prefer the intravenous antibiotics for about, say, 3 weeks, and then followed by oral if possible. And a decreasing trend of ESR CRP is the indication to continue beyond 3 to 6 weeks. And then we leave a period without antibiotics. And for me, it is about 6 weeks, but some people leave about 2 weeks as well and look for whether the ESR CRP again rising after you stop the antibiotics. Next, number 2, after the second stage reconstruction, the usual course of antibiotics, but in the second stage itself, we send the tissue for culture and wait for the culture report to come. And after culture report is negative, then we stop the antibiotics. Else, if there is a single growth of single tissue, then again we continue the antibiotics for about 6 weeks.
Thank you. Peter?
Yeah, so we so for one stage revision on that, we would go for 12 weeks. If so it all depends really what you end up doing. So sometimes you haven't got an organism at the beginning. So I mean, everyone, we tend to sort of use like ticaplanin and ciprofloxacin to begin with until we get the cultures back from the surgery, and then would try to get somebody then onto something oral as soon as we can. So if we can get somebody onto something oral quite quickly, then we would go for 12 weeks. If we've got the situation where we really don't have anything that's oral that we can give, which is not very common, but it does happen, we would probably go for 6. We would probably, go for 6 weeks at that point. It's just a practical consideration. But yeah, I mean, it's a really interesting question actually, because when you look at the Sheffield group, of course, the Sheffield group didn't continue antibiotics at all.
Yeah.
Even after one stage revision, and so there's different ways of doing things, absolutely. And I think, as Alasdair says, we're probably treating ourselves rather than treating the infection in a sense, in terms of giving antibiotics. But yeah, so we 6 to 12 weeks. Yeah.
And especially since we're using antibiotic-loaded cement, so that is eluding antibiotics for a little while. So Thank you for that. Peter, you did answer that question. This is my second question, which you've answered by saying that you use ticaplanin and ciprofloxacin if the cultures were negative. So if I can ask Alasdair and then Shubhranshu that if the cultures were negative for a patient, what antibiotic protocol would you use? Alasdair?
Alasdair, yeah.
Sorry, negative after the first stage, or negative?
No, so you've done your aspirations, everything is negative, but this patient was infected because he's got a discharging sinus or something, and you've done your revision. Have you got a set protocol of antibiotics that you use? You involve your microbiologist, or how do you go about it?
So we work very closely with microbiologists. So Tyco and Cipro is our standard default. And then it's a matter of looking at those samples and then coming up with a decision. And they stay on Tyco and Cipro till we've got an answer which is either better than that. And if we grow nothing, then we've got to go back. So we had a patient recently who had an infected aortic valve. He'd had his knee replacement done 15 years ago. He came to the cardiothoracic unit and eventually had a aortic valve replacement. We've never grown anything from his knee, but his knee's clinically infected. So we're basing on the fact it's probably from his endocarditis. So we're treating him antibiotic-wise for the bugs that grew on the heart valve, even though we've never grown anything from the knee. And that's the basis of most likely scenario.
Wonderful. Thank you. Shubhranshu?
If the cultures are negative, we put in a broad spectrum antibiotics which would cover, all the organisms probably. So my choice is that we put linezolid and aminoglycoside. Linezolid, why? Because it will cover gram-positive as well as MRSA. And the amikacin would be covering the gram-negative. And the advantage of linezolid that it can be given both IV as well as oral tablets available. And it's better that linezolid orally provides the same concentration in the blood, minimum inhibitory concentration like IV linezolid. So initially we start with IV, then just it's easier to transform it over to oral tablets. So we continue with linezolid and amikacin for about 3 weeks, and then we stop amikacin and continue with the tablets uplinazolate for about 6 weeks.
Shubhranshu, one more question to you has probably come from the Indian audience about fungal infection. So if you get fungal infection, how do you treat it? And I'm not sure whether Alasdair or Peter want to comment on that as well. Shubhranshu?
Yeah, it's first of all, there should be a high index of suspicion about fungal infection. When you see there is no growth in the culture, but a histopathologist tell that there are some fungal hyphae seen in the histopathology, then send the samples for a fungal culture. And in those kind of cases, if you want to do a first stage reconstruction, then it is usually amphotericin B or voriconazole. These are the two antifungals can be added to the cement. And these patients are very resistant to chemoprophylaxis, and one needs to treat this patient for at least 6 months with the oral antifungal treatment before going on to the second stage. Of course, you have to involve an infectious disease specialist, and they recommend like that. And the antifungal treatment, as you know, it has got a lot of effect on the kidney, and patients with renal compromise you have to be really worried, and you have to involve an infectious disease specialist, nephrologist in order to titrate the dose. So that is a nutshell about a fungal infection, but suspected in a diabetics, highly patient on immunosuppressant drugs, patient rheumatoids, those who are really, maybe you suspect some immunosuppression, those are the cases where you need to worry about a fungal infection.
Thanks a lot. Anything you want to add, Alasdair or Peter?
No, I just reiterate anything Professor Mohanty said. I think that was a very good summary.
Thank you.
Yeah, I've only treated, only seen 2 patients with a fungal infection, which probably means I've missed a lot in terms of looking for them, and I put amphotericin in the bone cement. But otherwise, I agree with what you said.
So, question to you, Peter. The question is, when you say that sometimes you might consider 2-stage if the immune status of the patient is not right, do you investigate to judge the patient's immunity, things like protein levels, vitamin D levels, or zinc, magnesium, all those investigations? Do you do anything of that sort?
No, I don't really treat immune deficient patients any differently as such. I would, I would use, even if I was worried about someone's immune status, I would always favor trying to do 1-stage revision if I could.
Yeah, you did mention that in your talk. Thank you. Alasdair, do you consider any of that, Shubhranshu?
Sorry, I didn't hear that. Sorry.
Do you consider investigating for things like protein levels, vitamin D, magnesium, zinc levels, etc.? For the elderly, infirm patients or anything?
No, I don't think we treat. No, I'd say I think you treat the patient the way that as they present to you. So the end stage, we're trying to treat an infected joint replacement, and that's a surgical procedure. The pre-op workup is whatever you would do for any other patient, maximizing their ability to go through surgery. So I think what we do from orthopedic surgeons doesn't change. It's the preoperative workup to try and get a bit, and then therefore there'll be a percentage of patients who are just not fit for surgery. We're going to treat them non-surgically.
Sure. Shubhranshu?
Routinely, though we don't do these things, but we check for the serum albumin level. If it's less than 2.53, then we are a bit concerned about treating this patient. First, we build up with the protein and these patients, and we look for the anemia. Many of the patients, they are anemic in our country, and we need to build up the hemoglobin. But specifically, if the patient is HIV positive, then we check for the CD4 count. If the CD4 count is less than 200, then we are very skeptic for these patients that it should go up. So at least we involve the infectious disease specialist again, to treat these HIV patients and bring at least the CD4 count to more than 200. Then we intervene this patient to undergo surgery.
Well, thank you for that. I think there's one more question and then we'll summarize. The DARE procedure, the question that has been asked is, should that, or in revisions, should we be revising our own infected cases, or should we be giving them to someone else? Are we more protective of our own cases? Can I ask that to Alasdair and then Shubhranshu and then Peter?
So in the UK, obviously, the NGR is there, and we all know the outcomes, and the outcome is decided as to whether someone goes to revision or not. And there's always therefore that possibility, if you don't revise somebody, then it doesn't come up as a revision on the NGR, irrespective of how good or bad they are. I would like to think that we should be treating all our patients appropriately. And I think that's where MDTs come in. You know, patients come in and they've got an infected joint replacement, and it's discussed in the MDT, and the MDT makes a decision as to whether that requires revision, whether it's 1 stage, 2 stage, whatever. Well, and then once that decision's been made, it's out of the hands of the surgeon who did the operation in the first place. Then what's important is the procedure is done by somebody who can do that procedure, which may be the surgeon did the operation in the first place, it may be somebody different. And I think by having, as we've got, and as up and down the country, it exists, well-working MDTs and honesty between surgeons, I would hope, therefore, that the appropriate surgery is done on the appropriate person by the appropriate surgeon.
Thank you. Peter?
No, I really support that. I mean, I think we're going through, obviously, lots of discussions about, we've started off with revision knee, and we're following that up now with discussions about revision hip. And I think it is so important, the sort of honesty behind that and what we're doing. I mean, it's been quite interesting when we've looked at the numbers of revisions that have been, so if you look at the NJR and look at the forms that are filled in, sometimes it's a bit difficult to distinguish between revision and their procedures if you've had a change of plastic insert and all the rest of it. And so there's obviously a discussion about expertise of what you've got. I mean, there have been some incidences where some units seem to be real experts in revision surgery, but that's possibly because they've really struggled with infection problems with their primaries. And I think also it's so useful, I think, an internal MDT as well, to have other people that you work with. The idea that you've done the case and then it looks like it's infected and you feel you honor bound to just look after it yourself is really not the place to be. And I think, to work with your colleagues and, to do it as a group, I think it makes a patient happier. And I think for you as a surgeon as well, it takes a lot of pressure off. And I mean, John Hodgkinson used to say, it's very easy to diagnose infection in somebody else's case, but almost impossible to diagnose it in your own. And I think there's an awful lot of truth to that, really. And when it comes to debridement and sort of extensive debridement and all the rest of it as well, I think if you haven't got that emotional tie with the patient, you can probably be much more effective as a surgeon, to be honest. So I really think the points Alasdair makes are really quite important about being honest, about working together, about having having MDTs that really function well. And I do think it just makes life easier for the surgeon if you share your problems, and it's much better.
That's pretty true, and I agree with John Hodgkinson. In fact, I think it's knee instability as well. We tend to diagnose instability much more with others than our own knees. Shubhranshu, what's your take on that?
Yeah, Nikhil, if my patient comes to me and I diagnose an infection, I would love to do it myself rather than sending to my colleague. Of course, what Peter told, you have to spend a little more time with this patient. You have to explain them the outcome, but you have to take a proper decision of that in which cases it will be successful. The patient is infected for a long time and he has been moving around with other surgeons, then probably that is not a good choice to do, and that it is not going to be very successful. So do it early, and I'll do it myself. Of course, I'll give the outcome, but if the DAR fails, then patient loses confidence in you and goes somewhere else of their own. So it has to be explained that the success rate, especially I tell it's about say 60-70% success, so that patient is aware that I may fall in the 30%, and always give more time to the patient, and I would do it myself because I would do the best job, I think. compared to.
Thank you
my
for that,
colleague.
Shubhranshu. I think that was pretty good. Thank you once again for all of you. I think it was really, really a fantastic webinar, and I like the fact that the discussions were so open and honest. And I would like to thank Alasdair, Peter, Shubhranshu for really giving your time. Again, I would like to thank OrthoTV, Ashok and Sham for being so helpful and giving us this platform, for Herius for the educational support. And just a reminder of the next webinar, which is on shoulder arthroplasty, Road to Success, on the 4th of July, and flyers will be coming out. Thanks you once again, everyone. Thank you.
Very much.
Thank you, Nikhil.
Right.
Bye-bye.
Thank you, Alasdair.
Bye,
Thank
Peter.
you.
Thank you.
Bye-bye. Thank you very much.
Thanks a lot.